you as primary care providers are in the front lines and that you hear and see a lot of difficult and overwhelming situations that can lead to burnout and to vicarious traumatization. Those responses have always been real. They are now more than ever real because as primary providers, you are encountering your own challenges in your everyday lives while having to remain responsive to your patients.
Welcome to the Health Pilots podcast, presented by the Center for Care Innovations. This podcast is about strengthening the health and well-being of historically underinvested communities. Every episode offers new ideas and practical advice that you can apply today. Dr. Alicia Lieberman, PhD, is a renowned psychologist, professor, author, and researcher who directs UCSF's Child Trauma Research Program. As one UCSF publication has said, Lieberman has spent her career trying to prevent and undo the emotional damage inflicted on very young children in violence-prone homes. Rather than simply decrying this state of affairs, she has instead designed interventions that mend and cement healthy and loving relationships between mothers and their young, troubled children. Moreover, in a follow-up study, she has found that the relationship-based interventions she designed had lasting positive effects. Simply put, Lieberman's work and achievements are staggering. She is the Irving B. Harris Endowed Chair in Infant Mental Health and Vice Chair for Academic Affairs at the UCSF Department of Psychiatry and the Director of Early Trauma Treatment Network. She has written many critically acclaimed books on child-parent attachment. As a trilingual and tricultural Jewish Latina born and raised in Paraguay, she has a special interest in cultural issues involving child development, child rearing, and child mental health. And as part of the CalQuick program overseen by CCI and UCSF's Center to Advance Trauma-Informed Healthcare, she has developed the TRIADS framework, a model for ACEs screening and strength-based counseling based on trust, empathy, consent, and mutual respect. In this segment, you will hear Dr. Lieberman as she talks about the importance of trust, dignity, and consent in screening for childhood trauma. This episode is adapted from a recent webinar. Enjoy.
I want to linger a little bit on the title of my talk, TRIADS Framework, an approach to understanding, helping, and healing people who experience trauma, because I think that it speaks regarding the centrality of relationships in the way that we approach this initiative. And the implicit message is that screening is not enough, that it needs to occur for the purpose of understanding how trauma is impacting health and how we use this understanding to help and heal. Again, the understanding, helping, and healing people who experience trauma and the centrality of relationships in this. And I'm hoping that as I talk, I can help make the implicit message of screening is not enough explicit, because that is how CalQuick and CCI want to implement the framework. I think we all hold this question of why screen for ACEs in primary care. And as Eddie said, I think perhaps the most succinct answer is that it's because screening can improve healthcare when done in a spirit of compassion and care. Much research evidence shows that giving a name to difficult experiences and to the feelings associated with those difficult experiences, what we call speaking the unspeakable, is actually helpful in regulating physiology and regulating the subjective experience of emotion and regulating behavioral expression of those emotions. And traditionally, for thousands of years, healthcare providers define themselves as taking care of the body, the mind, and the soul. And I think that we now want to help restore that tradition by widening the lens of healthcare to move from a biodisease focus to a holistic model of care based on trust, where the provider and the patient work together in understanding how the patient's life experiences are affecting health and behavior, and how to use positive influences to improve well-being. And this hope-oriented approach we find and research supports helps both the patient and the providers in increasing satisfaction in the healthcare relationship. We have to acknowledge that reality matters. And the epidemiological data shows that by age 16, over 2/3 of children have experienced a traumatic event. This is a time where the brain is still developing, when the sense of self is being formed, and when the understanding of what relationships are about is being created. So the way that trauma imprints the brain with a sense of unpredictability and danger cannot be overestimated. It's also important to remember that the first 5 years of life are the years where brain develops most quickly and where simultaneously there is the highest likelihood of child abuse, of witnessing domestic violence, and of accidental injury, often due to parental inexperience or actual neglect. And the brain is developed to respond to danger and to pain by freezing, fighting, or fleeing. And these experiences that are first emerging in childhood last the rest of our lives, and yet there is always the opportunity to work with them, to reframe them, and promote healthier responses. The continuum of stress responses go from normative stress in response to everyday challenges, and that actually increases resilience because it keeps us alert and responsive to manageable demands. Now, with COVID-19 and with the fires, we're facing an increase in the range of stresses that go from burdensome, like sheltering in place, economic hardship, feeling worried about how we're going to cope, to actual traumatic stress, like illness and death, which overwhelm our coping responses and make us respond with a persistent increase in stress hormones without a return to homeostasis. So that this chronic elevation becomes toxic and alters our emotions, so that we're angry, depressed, anxious, and respond often either with aggression or with withdrawal or with a numbing of our sense of empathy towards ourselves and towards others. And this awareness of the range from normative stress to toxic stress and the effort and the value that the primary health provider, the healthcare system, has in helping patients identify their toxic stress and move towards the middle of the continuum or towards finding ways of making burdensome stress more normative in its response. That is, I think, the challenge that we're experiencing right now. And for that, I think we need to remember that stress lives in the body and that being seen and heard by a trusted person actually promotes trust and offers relief. That is what enables us to grow in response to trauma. There is a wonderful song that you might know by Leonard Cohen, Anthem, where he talks about ringing the bells that can still ring and giving up our idea that perfection is possible and saying there is a crack in everything. We are all wounded, and yet it is through our woundedness that we can help ourselves and each other. And we have to remember that suffering can stimulate a search for meaning, compassion for others, and emotional growth, and that it is in the caring relationships that we have that we can promote healing. And primary care is a place where that can take place. This is the spirit of the triad. It is an effort, first and foremost, to give meaning, to use a holistic approach to healthcare that helps the patient understand, grasp the frame for why we do screening, by explaining to them that ACEs affects physical and emotional health, but that they have coping resources, sources of strength that will help them overcome their experiences of distress, and they can become active partners in their treatment plan. And the triad then involves 3 core ingredients. The screening for ACEs, which shows is done with an empathic interest in the sense of what happened to you. Assessing distress by asking supportively how the patient understands those early experiences of adversity and trauma as influencing how they are feeling in the here and now and how they are behaving in response to distress, and then helping them identify who helps them and what helps them, and use those strategies as integral components of the treatment plan. None of this occurs in a vacuum. And the elements of the triad framework, which are the screening and response, occur in the context of a holistic approach that involves 5 elements. And as Eddie said, Sarah Ismail will tell you how those 5 elements are represented in the website. And the 5 elements involve creating an environment that is calm, safe, and welcoming, both for patients and for ourselves and staff. And a foundation as the second element of values and policies that are informed by an understanding of trauma and resilience. The environment and the foundation become the context for educating patients about the connection between trauma and health and the role of protective factors, and connecting them to resources for safety and healing. And that education in turn becomes the context for the screening. Screening for what happened to them, how do they understand what happened to them is impacting them, and what and who helps them. And in response to the findings of the screening, the provider enacts a response that involves expressing empathy, addressing immediate safety, and collaborating with the family on referrals to promote safety, connection, and healing. Implicit in everything I said, I think, is a response to a question that is often asked, which is the concern of many primary care providers about re-traumatizing patients in the process of screening for ACEs. And I think that the fastest way of explaining why ACEs screening embedded in the context of also asking about distress and also asking about strengths in an environment that promotes calm and welcoming attitudes is that trauma is unpredictable, uncontrollable, overwhelming. It shatters expectations of safety and predictability, and it creates shame and guilt. The triads approach and the framework in which the triads approach is embedded does the opposite of all that, so that it actually corrects traumatic expectations and affirms the patient's dignity. because it is done with consent. It creates a manageable environment where there is a dialogue that is caring and invested emotionally between the provider and the patient. It gives meaning by explaining the rationale for the screening, and it gives the patient permission for maintaining control by asking, for example, how are they feeling as we ask the questions, and by saying to the patient that they can opt not to respond. And it's very clear in everything we do that what we're doing is for the desire to help, and that the patient is being empowered by becoming a partner in the treatment plan. I think in doing all this, we have to remember that there are dangers to caring, that you as primary care providers are in the front lines, and that you hear and see a lot of difficult and overwhelming situations that can lead to burnout and to vicarious traumatization. Those responses have always been real. They are now more than ever real because as primary providers, you are encountering your own challenges in your everyday lives while having to remain responsive to your patients. And I think here we need to remember that self-care is patient care, and self-care is essential to remain effective. And that we need to practice what we teach our patients about cultivating time out, protecting our private life, seeking out consultation and support from our colleagues, and building support systems at work. We also need to remember that there's a crack in everything, and that mistakes can be repaired, that we are all learning together, that small changes matter, and that everybody can be therapeutic without necessarily being a therapist. And actually, sometimes the most humble people in an organization can create the most transformational care through their investment in the people that they connect to. I think one thing to remember is that often the clinic staff with the least organizational power are the ones who are asked to do the screening. And often that person thinks that they are just supposed to kind of give the patient the forms to fill out, and that it's the doctor who is going to have the therapeutic role in how to interpret the forms. And I think that it's exactly the reverse, that the person doing the screening, regardless of her or his position in the organization, by being the first point of contact, is the person that gives to the patients the message of how much the clinic cares and how interested the clinic is in the patient's experience and on how they are responding to those experiences. And I want to end by reminding ourselves that we can all make a difference, one provider, one clinic, one healthcare system at a time. I was driving around Santa Cruz before the pandemic and saw a graffiti that said, "If nothing changes, nothing changes," by an anonymous street philosopher. And it reminded me of what Ken Epstein said in creating his Trauma Transformed initiative that educates systems of care to become trauma and resilience informed. What will change when a system becomes trauma informed? Everything. And I'm hoping to go back to that graffiti and write that quote underneath that, the first one, "If nothing changes, nothing changes," so that we can provide hope. Thank you very much.